Hello, and welcome to the Rosa Worldwide webinar series. My name is Mike Reed. I'm the Chief Scientist at Rosa, and I'm happy to welcome you to today's webinar. Our speaker today is Alvaro Ruiz-Martinez from Rosa. He has 12 years of computational and modeling experience related to mechanical, chemical, and biological systems. He's developed models focused on immuno-oncology, biopolymer assembly, and pharmacokinetics and pharmacodynamics. Dr. Ruiz-Martinez received his Ph.D. in mechanical engineering from the University of California at San Diego and his postdoctoral degree from Johns Hopkins University. Joining him in today's webinar is Vincent Jerez, a former Rosa scientist who is currently Director of Quantitative Pharmacology at Regeneron. I'll remind the listeners that you can enter questions and answers by clicking on the Q&A button at the bottom of your screen. The authors will be available to answer questions at the end of the talk, which we're going to do by video today. I'll also remind everybody that you can check the website for upcoming webinars on the Rosa & Co. website. Welcome, Alvaro and Vincent, and look forward to your speaking.
Thank you.
Thank you, Mike.
Hello. This presentation is about the mathematical optimization of a thrombopoiesis QSP model with the goal of improving chemotherapy dosing. First, we'll present an introduction, then we'll explain some of the scientific and technical background, then we'll focus on the development of the QSP model. After that, we'll show some simulations related to chemotherapy, and finally, we'll summarize the conclusions of the project. So in this project, we had two main goals. One was technical, and the other one was focused on the biological applications of the model. The technical was about optimizing the thrombopoiesis model by improving accuracy and simplicity with respect to previous models. The biological goal was about thrombocytopenia, that is, the low number of platelets in the blood. This process, thrombocytopenia, is a common concern with chemotherapy. Now, published models of platelet dynamics and regulation of thrombopoiesis, that is the process of production of platelets in the blood, often use complex mathematical formulations. In this project, we have developed a simpler fit-for-purpose thrombopoiesis QSP model using MATLAB in biology with a minimal structure that reproduces experimental data by integrating and improving published models, parameters, and equations, and evaluating the response to chemotherapies of a virtual patient with normal platelet levels, and a thrombocytopenic VP corresponding to acute myeloid leukemia patients, AML. The scientific background is summarized here, and we have two important processes to talk about. Megakaryopoiesis, that is the process by which mature megakaryocytes develop from hematopoietic stem cells, and it is characterized by 4 steps: proliferation in early stages, endomitosis, which leads to polyploid megakaryocytes, post-replicative stage with megakaryocytes cytoplasmic maturation, and pro-platelet formation and megakaryocyte fragmentation. Now, the other process is thrombopoiesis that results from cytoplasmic fragmentation of megakaryocytes, and it is dependent on their number and size. There is an important element, a major regulator of these two processes that we included in the model, like other authors did, that is thrombopoietin, TPO. Now, as we mentioned, the main goal is focused on chemotherapy, since chemotherapy can have adverse effects on this megakaryocyte and platelet productions. From the technical point of view, we realized that representing these processes could be challenging. We saw different models in literature. Some of them focus on the reproduction of observed oscillations in the platelet counts of normal humans. Others explore the origins of cyclic thrombocytopenia, and others focus on platelet dynamics in response to chemotherapy in cancer patients. Now, our QSP model is based on a recent QSP model focused on thrombocytopenia, CIMISU model from 2020. Its mathematical formulation is simple, but megakaryopoiesis process was not accurately represented. Now, we took another model to improve that. The other model from 2017, Longlua model, provided ideas to optimize the former model. Nevertheless, its more complicated formulation based on system of integro-differential equations with delay require more computational resources to guarantee accurate solutions. In terms of model development, we'll start by showing the diagram, the figure that is in CIMISU's paper, where we have different species. We have the bone marrow compartment here in light pink on the left, and we have the blood compartment on the right with other two compartments, liver and spleen, that we do not represent explicitly in our model. We represented only bone marrow and blood as different compartments. Now, the process represented in bone marrow is the megakaryopoiesis process, where we start from the top with stem cells, and then if we go from top to bottom, we see different stages in this process. We have progenitor cells, the megakaryoblast, and the megakaryocytes at the bottom. Megakaryocytes produce platelets in the blood, and these platelets regulate TPO clearance rate. Now, TPO has an effect on megakaryopoiesis process, and also the cells in the bone marrow have an effect on TPO clearance rate. So these processes were represented in our model, but we had to introduce some modifications because we realized that there were things that were not accurately represented. The first one is that we added a constant source of stem cells equivalent to Longlua model. The second one is that we reduced the number of progenitor cell species from 27 to 8. That is consistent with 8 days mitosis process from Longlua analysis and other references in literature. Now, these two modifications were critical to capture the timing of the process. CIMISU's model was correct and accurate in terms of cell levels, but in terms of timing, there was a significant delay due to the number of species defined for progenitor cells. Instead, the combination of a stem cell source plus 8 species was much more accurate and consistent with the data. A third correction was implemented related to the TPO effect on megakaryopoiesis. We also realized that in CIMISU's model, TPO didn't really have an effect on megakaryopoiesis process. Only in the last step, related to megakaryocyte production, but not in the previous steps. Finally, another modification that we implemented was the TPO dynamics that we took from Langlois, since the representation was much more simple and it didn't require the complexity of Simisus paper. Here in this slide, we see the diagram of our model, and as we mentioned, we have the bone marrow compartment on the left and the blood compartment on the right. We see in dark blue the main species, progenitor cells, megakaryoblast, megakaryocytes, and platelets in the blood. Now we have TPO in blood in light blue on the top right, and TPO in the bone marrow on the left. We also have two chemotherapies that we implemented, azacitidine, AZA, in orange, and venetoclax, also in orange. Their PK compartments are not represented here, but they were also implemented in the model. Now, after defining the equations and the main species of the model, we also created two virtual patients. We created a reference virtual patient, or healthy VP, that represents an average healthy individual with normal platelet levels of platelets, also normal levels of progenitor cells and megakaryocytes, and plasma TPO. The baseline values were calibrated to match reported average cell numbers and TPO levels in thrombopoiesis model publications. Only 2 out of 20 parameters needed to be calibrated to fit data from literature. The rest of the parameters were taken from literature or calculated to achieve a steady state equilibrium in untreated conditions, meaning stable cell levels and TPO levels over time for the healthy VP. The second patient we created was a thrombocytopenic AML VP, and we created it by reducing the stem cell production by 75%. That implied lower bone marrow cell and lower platelet levels, and also higher TPO levels. Those levels were consistent with thrombocytopenic AML patients. Now, the next 2 slides will show the quantitative results, the quantitative tests that we performed to calibrate the healthy VP. Now, this first test was about administering a TPO IV bolus dose and see the effect of it on platelet levels. TPO bolus is injected at time t equals 0, as we can see on the figure on the top left. It decreases over time and it goes back to baseline levels. TPO in bone marrow, here at the bottom, starts from baseline values, reaches a peak, and then goes back to baseline values. Now that TPO bolus dose increases platelet levels, as we can see on the figure on the right, and after calibrating, as we mentioned, 2 parameters, we were able to fit the dynamics from that we got from data from a paper from 2004. Here at the bottom, there is this reference, 2004. We took this data to make sure that the peak was consistent with the data, the peak at 10 days after this TPO injection, and the return to baseline levels after 3.5 weeks. The second test was about checking, making sure that the half-life of the cells that we represent is consistent with the data. Now, for this test, we assume that the stem cell source is blocked So there's no more production of cells in the bone marrow. That means that cell levels should decay to zero over time. That is what we see on the figures on the right. Now we can see we have data, there is literature about the half-life of megakaryocytes and platelets in blood. And the half-life that we obtain from our simulations is consistent with the data. 7 days, around 7 days for megakaryocytes, the concentrations of megakaryocytes decreased by half in 7 days, and for platelets in around 9 days. Now, in terms of chemotherapy, we have to implement pharmacokinetics, PK, and pharmacodynamics in our model. For PK calibration, we use models from literature. We implemented these models. Here on the top, we see ASA. We implemented a one-compartment model from Gaudi 2023. But we have to refine the calibration to really get an accurate representation of this chemotherapy. For venetoclax, we use a two-compartment model from Samineni 2022, and also we have to refine the calibration. For the pharmacodynamic simulations, the Ph.D. simulations, we also needed references from literature. We collected different references that we can see here on the table on the top right. And this data was basically from ASA monotherapy and from ASA plus venetoclax combination chemotherapy. Venetoclax by itself wasn't applied because it didn't have an effect unless it was combined with ASA. So what we did, we used this data to calibrate the PD parameters of our model. We simulated two different scenarios, one on the bottom left for monotherapy, one on the bottom right for the combined chemotherapy. And we can see that after calibrating these parameters, we were able to capture the dynamic in both scenarios, for the monotherapy on the left, for the combined chemotherapy on the right. These data points are basically from these references that we include in this table on the top right. Now that we defined our model, we created our model and tested, we wanted to see how these chemotherapies affected our reference our VPs, the reference VP on the left and the AML-VP on the right. Now we applied dosing protocols based on what we see in literature in from clinical data. And when we applied these protocols in these VPs, we saw that the reference VP, the healthy VP, was not the platelet levels of the reference VP didn't decrease to risky levels. Hello. We saw that the reference VP, the healthy VP, was not the platelet levels of the reference VP didn't decrease to risky levels for the monotherapy. However, for the combination therapy, we see that we reach that the chemotherapy induces at least grade 3 thrombocytopenia to the healthy VP. Now, for the AML VP on the right, because it has, by default, it has lower platelet levels than healthy VP, we see that the monotherapy induces grade 3 thrombocytopenia, and the combination of chemotherapy decreases the levels, sometimes even close to zero. It induces grade 4 thrombocytopenia. We also check that the TPO levels or the increment in TPO levels was consistent with data. And as we can see on the right, we see the TPO levels for the reference VP, the TPO levels in blood on the top, the TPO levels on the bone marrow at the bottom. These levels increase by at least double with respect to the baseline levels for the combination therapy, which is consistent with the data that we saw on the left from this reference, Gonen 2005, where the levels after applying chemotherapy double the levels of TPO in these patients. Conclusions. Well, we have developed, we presented an efficient fit-for-purpose thrombopoiesis QSP model that simulates megakaryopoiesis and platelet dynamics. The megakaryopoiesis, thrombopoiesis, and thrombopoiesis timing, as well as TPO dynamics, are accurately represented. The model has been successfully tested for the chemotherapies we implemented, and we notice, although we don't include the results here, but we analyze the model by reducing the number of species in the bone marrow, because in our model, although we didn't show in the diagram, there are intermediate species for progenitor cells, megakaryoblast, and platelets, as Simisu did. We tried to reduce the number of intermediate species, and the results were not accurate anymore. So the way we represented the intermediate species was optimal to capture the results and to capture the biology while reducing to the minimum the number of species and the complexity of the model. Finally, the model can be used for predicting thrombocytopenia risk, mitigating risk by optimizing protocols, or designing effective concomitant treatment protocols for thrombocytopenia. So thank you very much, and please do not hesitate to ask questions to Vincent and to me during the rest of the webinar. Thank you.
Thank you, Alvaro. We do have a couple of questions, some of them technical. Can you just tell us, roughly speaking, how many ordinary differential equations and parameters there are in the model? And you might be on mute right now.
Okay. Can you hear now?
Yes.
Okay, sure. In terms of equations, right now I'm thinking we have 8 for progenitor cells. We mentioned that here. Mm-hmm. When we reduce the number of species for progenitor cells with respect to the original paper. So 8, I would say 8 plus 5 megakaryoblast, 13 mm-hmm. plus 1 for megakaryocytes, 14. There were 9 for platelets, so 23 plus 24, 25, 26, 27, I would say, something like that.
Okay, so roughly
between 25 and 30.
Okay. Mm-hmm. And yeah. So can you talk a little bit about how you create the characteristics of a virtual patient, and how you would represent a virtual patient that has another disease indication or another physiologic variability that you might see in a clinical patient? This might be a question for Vincent.
Yeah, let me go. Also, I think the previous question asked about the parameters, and I mentioned that here in this slide is around 20 parameters.
Okay, thank you.
The one we define. Yeah, and this is also the slide for that question. Maybe Vincent wants to start answering.
Do you want to answer, Alvaro, or should I?
I can answer. I mean, to define the VPs, we have here some information in this slide. The reference VP, that is a healthy VP. We took the approach we took here is we use values mostly from Simisus paper for cell levels, from Longroa paper for TPO levels. We use the same values because we did our own research and we checked that those values were reasonable, were consistent with the references in literature. So we didn't see the necessity of changing those values. We realized that the main issue with the model, it was about the equations more than the parameters. And as I mentioned, the timing, the intermediate species was critical for the time to capture the timing of the processes. And in terms of creating a different VP, we created these two, but we could create more depending on the what we try to represent, the case we try to represent. But this one, we realized that. I mean, we doing research also about cell levels and TPO levels in AML BP or patients, real patients. We saw that the cell levels was lower, around 1 order of magnitude lower than healthy patients, and higher TPO levels. So what we assume is that the assumption we took is that the stem cell production was lower in that type of patient. I mean, we could make other assumptions or choose different values, but by making that assumption, you calculate what will be the steady state levels for that patient, and we got these values on the right on the table, and that's the way we define the second patient. Again, depending on the case you want to represent, you can define the values by yourself, or just assuming that some productions and clearance rates of some species are not have different values than the healthy VP.
Thank you. And anything to add then, Vincent, about how the life scientist identifies the characteristics to model?
Sure. So I think as Alvaro mentioned here, we represented just one AML perturbations, but in the literature, there are actually a range of severity, some with thrombocytopenia and some without thrombocytopenia. So the healthy reference VP was representing more the one that didn't have thrombocytopenia. Some of the parameters that could be affected by the disease, it looks like in some subset of patients, the AML tumor itself expressed the TPO receptor. So we could potentially have different patients with different clearance of the TPO receptor based on receptor expression and tumor burden, but the tumor burden was not implemented in this more simple platform.
Thank you. Can either of you guys comment on how you would represent other drugs or combinations of drugs in a platform like this?
Yeah, I can comment on that. In fact, I want to mention that the way we implemented these drugs, these chemotherapies, is by introducing some effects on the clearance rates of the cells here, megakaryocytes, megakaryocytes, and the effect we introduce. I mean, technically, what we use is basically Hill functions to introduce the effect, to implement the effect of ASA, and venetoclax was implemented as a chemotherapy that only has an effect on the cells or on the clearance rate of those cells if it's combined with ASA. So basically, the way this was implemented is that potentiating, I mean, these chemotherapies potentiate the clearance rate of these cells. Other drugs, depending on how they interact with the cells, with the species in this model, maybe if they affect the production instead of the clearance rate, then we will implement something similar, but with different effect, of course.
Thank you. That's all the questions that we have. So at this point, I'd like to thank our speakers, Alvaro and Vincent, and I'd like to thank the audience for joining us. Just a reminder to check the Rosa website for upcoming webinars in our monthly series, and we look forward to meeting with you next time. Thanks, everyone, and have a nice day. Bye-bye.
Thank you.
Thank you.